So having dense breast tissue is really a critical issue.
So when you have dense breast tissue, first of all, it has nothing to do with the way they feel or the size. It's really talking about what the breast looks like on mammography. So if you have dense breast tissue, that just means that your breast tissue, when we do a mammogram, it's very white, and breast cancer is also white. So trying to find that small white cancer in the background of white glandular tissue, it's definitely more difficult.
It may help to just take a step back and say, what is density in relation to water? Does it float or does it sink? And so something that floats is less dense, like fat. So x-rays can go through fat pretty easily. Now something that sinks, that's more dense tissue. And in other words, it's like fibroglandular tissue of the breast. So that is more difficult for the x-rays to penetrate through.
Women with dense breast tissue are the perfect storm, right? That mammography, although in women with predominantly fatty breasts is 90% effective or sensitive, in women with dense breast tissue, it's only about 85, or in some studies 50% or even less effective at identifying early breast cancer.
Currently, the only thing you can do is what does your mammogram say? So mammogram divides it up into 4 categories, and the 2 highest categories of heterogeneous or extremely dense breasts are what we refer to as women with dense breasts. But that's about 40% of the population.
So when you get that letter in the mail that says you have dense breast tissue, then some of the options you have are, number 1, you should find out if you just got a normal 2D mammogram, which is the standard mammography right now. But a lot of facilities offer digital breast tomosynthesis, also known as 3D mammography, and that's definitely better for women that have dense breast tissue. So you want to find out if you got digital breast tomosynthesis or 3D mammogram. The other thing is we do offer ultrasound for women with dense breast tissue, and studies have shown that we're able to find additional cancers with ultrasound when performed in addition to mammogram. The third option is MRI, but MRI is really it's really for women that are at high risk for developing breast cancer. So in addition to knowing whether you have dense breast tissue or not, you should talk to your doctor about your lifetime risk of developing breast cancer. When it comes to breast ultrasound, dense breast tissue will appear white, but breast cancer appears dark. So when you have white background and you're looking for dark cancer, it's easier to see. So that's why breast ultrasound is the best imaging modality, supplemental imaging modality for women that have dense breast tissue. And also remember, with ultrasound, there's no radiation. So, and there's no injection. Unlike MRI, you have to have the IV gadolinium. Some patients can't have MRI because if you have renal disease or, certain medical conditions, you can't have MRI. If you have a pacemaker, if you have claustrophobia. But with ultrasound, it's very safe. We use it in pregnant women to look at babies. So it's very safe. And so it's a great supplemental exam to mammogram for women with dense breast tissue.
So we found that initially sort of the legacy technology of screening breast ultrasound is that it's very effective. that we find 25% more breast cancers with screening breast ultrasound in women with dense breasts. And the thing to remember about these cancers is that they're really important cancers. And you might say, well, every cancer is important, right? But these are small, invasive, almost predominantly, almost exclusively node-negative cancers. So these are killer cancers that if we find early, we can cure. And so that was early data. Then ABIS came out, which is automated whole breast ultrasound. And we found, well, you know, that data showed that we can find the same number of cancers and it was automated. But, and so that's the development of technology and innovation, and I feel very lucky that I was part of that process as well. But there were a couple of things. One is, it really wasn't designed to be done at the same time that a woman is seen. So she would have to come back for another visit, and that would put such a big obstacle in really widespread implementation. The second is that it was uncomfortable, that it is uncomfortable. It requires a fair amount of compression on the breast, and women do complain about that fairly consistently. And then finally, the callback rate is very high. It's very high, almost unacceptably high. And so we do have the opportunity to find more cancers, but the callback rate requiring more ultrasound, more biopsies, is really too high. And I think that's one of the reasons, primary reasons, that it hasn't become as widely implemented in clinical practice as one would expect, right?
I was part of the Akron 6666 trial where we did whole breast ultrasound in high-risk patients. And we saw that there was a need for breast ultrasound in patients because we were able to find additional cancers in patients by doing whole breast ultrasound. But at the time, we saw that it actually had too many false positives, too many unnecessary biopsies. And so it was not something that we were able to say, okay, I think everyone would benefit from ultrasound.
As far as supplementary imaging options, MR has been considered the gold standard as finding the most cancers in women with dense breasts, etc. But there's a problem for that. It's not approved as an actual adjunct to screening at this point, and it requires an intravenous injection. There's problems with claustrophobia. There's problems with access to the equipment. You need MR equipment, which is very expensive. And to continue to improve, you have to have higher strength magnets, which gets even more expensive. So there's quite a limitation. Along those lines of requiring an injection would be contrast enhanced mammography. Similar problem, similar concept. You're trying to inject something that enhances early developing cancers. And so that's where you don't require an injection with Softvue, and yet we're still finding those extra cancers. Softvue is a whole new form of ultrasound. And what I mean by that is standard ultrasound has for the longest time relied upon sending out a signal, it bounces off the tissues and comes back to the transducer. Thereby it's called reflection ultrasound. And that's been very good as far as characterizing and finding masses in dense tissues. So that's why ultrasound has been used for a long time. The big difference with Softvue is that it also gathers transmission images. It actually shoots through the breast. The two things you get by shooting all the way through the breast is you can time it from one side to the other, speed of sound. You can then say, well, how is the strength of the signal the same? No, you can actually get attenuation. So those two are quantitative measurements. So we actually have, instead of one way of characterizing reflection, we've got three ways. And that's why we call it the triad of imaging.
We have the opportunity to find early, curable, invasive breast cancers in a painless way because of the way the patient is imaged. She's imaged prone, with her, meaning on her stomach, with her breast hanging in a water bath, a very comfortable position. There's no compression at all. Women find this very comfortable. We do it, it's designed to be done the same day, and perhaps perhaps sort of most mind-boggling is that we can do all that because of the really novel technology and decrease the number of biopsies. We have a tool that we can find more cancers with less callbacks, less negative biopsies. So it's a humongous transformational contribution to the field.
Just thinking about what this technology can do for patients, it's really exciting because we have this need to do breast ultrasound in women with dense breast tissue. I think nobody would argue that, but to not decrease specificity, I think that's just so important.
A woman would come in, she has a very discreet gown over her, so it's not like other exams where you feel exposed, you feel discomfort. She simply lies down, and with a technician, and it doesn't have to be an ultrasound technician or a mammography, it can be a trained person who just gently guides the woman into the hole in the table, which then gets engaged by the secure breast interface, which I can explain in a minute, but that just gently extends the breast into the warm water so we can get the full scan. The scan starts at the nipple and only takes about a minute or two to scan all the way up to the chest wall, and then the breast is exchanged for the other breast and the process is repeated. And so literally within 10 minutes of walking in the door, you're walking out with the entire breast inseminated and scanned and then to be reconstructed and interpreted.
Traditional ultrasound, you have a transducer that emits a wave, right? And then the transducer, it bounces off tissue, and that's how the image, of course, is generated. But what we need to do is really talk about tissue properties. And the way we can do that is by not only having reflection, but transmission. So with the Triad technology, we have a ring transducer and opportunities to image with both reflection and sound waves that go through tissue because of the circular transducer where it's through the tissue. And as a result of that, we can get tissue properties. And it's that tissue property component that allows us to not only find more cancers, but to understand the tissue properties to decrease the number of biopsies of benign lesions.
Up until now, breast ultrasound actually decreased specificity with increase in unnecessary biopsies.
Standard ultrasound is almost like a painting. It's operator dependent. How do you paint the picture? By moving this, transducer all over the breast. Did you get all of the breast? You're not quite sure sometimes. And the woman is lying on her back and sometimes the breast moves. Whereas a ring array captures the woman lying still with her breast in water and be able to scan all the way from the nipple all the way up. But it also scans all the way around the breast. Now we get the transmission signals. We get to see a mass from all sides, not just from the skin surface. We also get to see it going through the deep part of the breast, where a lot of times even regular reflection ultrasound has difficulties penetrating deep in the breast, especially with somebody with dense breast.
I think it's just wonderful that we can actually do screening mammogram and screening ultrasound on the same day. Yeah. And we can actually interpret mammogram and Softview together.
To talk about sensitivity and specificity, those are fairly technical terms that, a lot of times, unless you're an academic radiologist, you don't really even understand the full implications of it. So sensitivity is nothing more than finding more cancers. And so then that is a good thing, because you find a cancer early, you prevent it from becoming a killer, and thereby you save lives. So that all sounds great, but it's like, what price do you pay for that? And to have high sensitivity, you usually pay a price in specificity. And we've seen that with standard handheld ultrasound and even, breast MR. And so what we were able to accomplish was very similar to handheld, and along the lines of MR, of finding 20% more cancers. So our sensitivity significantly improved, and the specificity is where it was a surprise to me that all these additional parameters of analyzing tissue came into play and say, no, that one is pretty much benign, don't worry about it. Whereas now that one over there, I still am not quite sure of. So yes, that is worth a callback. But not only worth a callback where they usually characterize it, but we've already characterized it in that process. So we're able to not biopsy the things that don't need to be biopsied. So that was an 8% improvement in specificity, as well as finding more cancers. So now that's the holy grail of being able to do screening, because you get more bang for the buck. More cancers for less inconvenience to the patient, and more savings for our healthcare.
For many years, due to very dense breasts, done the very isolated imaging, and also have done ultrasounds to understand the dense spots that I have. My experiences with the spot compressions have been pretty uncomfortable. They end up being, a lot of compression, a lot of pain. It requires you to, hold your breath and stand in a very interesting or unique position so that they can get the proper image. I understand why it's needed, but it's not usually a very pleasant experience to have the spot compression and the very isolated testing. My experiences with handheld ultrasound have been less painful and uncomfortable compared to some of the traditional mammogram type compressions, but still it requires you to lay in a position, and they can take a long time, and they can be uncomfortable. You're exposed to the room and things like that. So my experience with Softvue was really pleasant. It was a non-invasive, very relaxing. I found that it was really comfortable. Essentially you're just kind of laying there and the machine does all the work. You're not required to put your head in any weird position. I wasn't required to hold my breath for periods of time. There was no pain. It was actually really, I joked with them, I'm like, I could fall asleep right now. I would definitely recommend this procedure for other women. I would imagine that it would encourage other women who maybe have heard that traditional imaging is painful, that they may stay away from it. This could be a nice way to get women to ensure that they're taking good care of themselves, since it was relaxing and comfortable.
We have some very exciting data currently with Softvue. One is that we can identify breast density as well as mammography with no ionizing radiation. So if you think about the impact of that, right? Young women ask all the time, well, what's my breast density? We're not going to use ionizing radiation on young women to figure that out, but now we can, particularly as the incidence of breast cancer, the age at presentation is decreasing. So this is really the first reliable demonstration of breast density with no ionizing radiation.
And Softvue actually measures some of the quantitative aspects of the breast, and one of those things is sound speed. So the fast as something travels through tissue will relate to the actual makeup of that tissue. So we understand what is fat and what is fibroglandular. So we can now understand what is a woman's life course of having dense breasts, because all young women don't have necessarily dense breasts, and all older women don't necessarily have fatty breasts. So there's always that mixture that you can now find out very early on with women with dense breasts, even in their 20s.
And another indication of the physiologic information we get is we have some really exciting preliminary data that after one round of neoadjuvant chemotherapy using Softvue, we can determine if someone is going to respond based on the characteristics of the tumor following the neoadjuvant chemotherapy. And wouldn't it be, it's like mind-boggling to think that we don't have to subject a woman to multiple rounds of chemotherapy to see if it's going to work.
And we've seen that cancers get softer and smaller, and we've been able to predict which of those cancers go on to have a complete remission versus just a partial remission. That might reduce the amount of chemotherapy we need, be able to time surgery better.
If we can diagnose early curable breast cancer with continual innovation and implementation of new technologies, then we're making the world a better place, and that's why SoftVue is so important.